So this is our December AP class. This is 1213, and we are going to go and explore some of the same concepts that we worked on yesterday, get in more depth on the PowerPoint and some discussion on that kind of information. I said something before the class was recorded that I thought was relatively profound. So I want to repeat it here, which is there are a lot of different ways to do something. Yeah, and we ended up exploring some temporomandibular joint stuff yesterday. It wasn't necessarily on the schedule, but you know how it goes, right? So what I tend to teach is the stuff that over the years I've taken a class or two or three or four or investigated on my own. And then and there's just a natural sort of what happens in professional practice on, this works as good as that, and this is easier for me to do. Or over a series of clients, this person, they respond similarly, whether I do this invasive method or not. And I think that when you start swirling around in a lot of the same stuff over and over and over many years, you start to have that natural ability to go, this isn't worth it. This approach to this is not worth it. And how I construct my professional practice and what I'm trying to do. And then I try to simplify things so that they're easily integrated into the general massage. A lot of what I've taken is more osteopathic or physical therapy or something like that. And while there's a big scope of practice overlap, our environment and our presentation is different. And so, I'll fiddle around and massage the methods so that the integrity is still there, but it fits better into our scope of practice. And so I would make an educated guess that if given time, a massage therapist who's been diligent and able to take multiple classes on the same topic would find that they end up in similar places. But today that is almost unwielding to take, like we were working yesterday with the temporomandibular joint idea, take that same content from 10 different instructors. Sort of kind of can't do that like I was able to do back in the day. And how I keep up with it with research and stuff. And so one of the things that I bring as value that's worth paying me for is that I've done a pre-sort on this stuff. And so you don't have to necessarily take the same series of classes I've done to find the nuggets, the overlapping nuggets of what works. That doesn't mean that there isn't other ways that's valuable and that you want to not explore these from other researchers or authors or teachers or presenters. But I think that if you compare what you might encounter, like if you go to YouTube and look at stuff, there's a lot of stuff out there about TMJ or headache or low back or shoulder. There's a lot of stuff out there. If you screen that through what you've learned while you've been with myself and with Luke, I think that you can get down to the nuggets of what are applicable, what have a high ability to help the person do better and feel better. And so that pre-sort is valuable. But I don't want you to get stuck in the methods either. I want you to be critical thinkers and look at stuff and be innovative in of yourself. If you find a way to accomplish the same thing that's easier or easier for you, because if it's easier for you, it's probably easier for somebody else too than what we've showed you, then it's important to share that as well. So let me get this out of here. I always have to figure out how to do that. I think I have to hit. There we are. Okay. So there's a picture of me here. I want you to notice that my hair is combed. And that I look, relatively gorgeous. And then there's this picture. And it's improved from what I did when I looked in the mirror this morning. So oh, that's the problem with these video calls. They can actually see what you look like for real. So yesterday, Luke and I tried, and I think fairly successfully produced kind of a hands-on class. What was missing was your ability to practice it and us be right there to guide the practice, but we'll be back in the classroom to do that. I did review the video. Did anybody else review the video? There are times when I laughed right out loud. The one where we were working with the neck movement. And there were a couple of others. And I do so drive Luke. He's so sweet, but I do just drive him to distraction. Linda?
I did notice that during it when we were recording that it was quite amusing.
Yeah.
I liked when you kissed him on the head.
I did too. You really threw him for a loop there.
And then when I did that chop,
Yep.
I'm going to show you with the suboccipitals, because sometimes I'll say, let's chop somebody's head off, right? They've got that herd of dogs right now, all those leader dogs over there. And I'm sure he thought that somebody had fallen down or the dog had knocked something down or something. So, and then as I was yanking his ear around, I thought that was also relatively hysterical. So, but I thought the content came across really quite well. And that when Luke changed the view and moved the, our setup, the music stand up, and tipped it, you could see right on top of what was going on. I thought that worked out really well. Anybody else have any, because we're learning too about this. Anybody else have any questions or comments on the process or suggestions on how we might have improved it for you?
No, but I practiced on my dog and he didn't like his ears being pulled like that. So
hey. You might have been a tad too aggressive.
I think he thought so too.
You go just two bind, and then just through. Any other questions or comments or suggestions that, because we may be doing this yet for a couple, 3 months. Just, I hope we can get into the classroom after the first of the year, but it's still valuable to record this stuff so that you can, in real time. I don't, we may be forced where Luke and I will be in a situation where we will do a demo, which is actually what I thought we were going to do, was pre-record some videos for you on this. And then a couple of things happened. We had some schedule overlap, and the timing that we had set in that, we couldn't do it. And so, plan A, plan B, plan C. But we wanted to capture a flavor of the classroom, and you guys did a good job bringing your own 2 cents worth in, And every time you'd move around, you know, the way that screen is set up, or say something, your faces would pop up. And I had a few chuckles about that too. Oh, grief. Linda, did you try to load your book on your
Yep.
computer?
Yes, I got it done, and I was even listening to it this morning.
And then Linda did find a paper version on Amazon. So you know, that book is an excellent book. But it was written back in 2005, 6, 7, 8, right in that area, right in there. And that was kind of where there was, actually started in 2000, but there was this movement in massage to move towards the medical model to legitimize. I also liked when Luke brought me a Kleenex because my nose was dripping.
Yeah.
I thought that was very sweet. So we, you know, the massage has struggled with its professional identity for years and years and years and years. On one hand, there's a group of people that really are osteopathic wannabes or physical therapy wannabes or athletic trainer wannabes, and they want to incorporate that whole scope of practice and the skill set and all that, but they don't want to go to school for it. And I have, you've heard me say that over and over. I've had a problem with that for years and years and years and years and years. So it's not the methods. The methods, there's a tremendous overlap in the methods. Muscle energy technique is muscle energy technique is muscle energy technique. Trigger point-ish focus is the same across the board. Assessment for range of motion of a jointed area, that's no different depending on the discipline that's doing it. But there's a big difference in somebody who has had a vocational level training like we present, and I strongly, strongly support, and somebody who's got a doctorate. And the expectation for somebody who has a doctorate or a master's degree is that they should be able to navigate much more complex and overlapping, called comorbid situations. They should be able to sort or have access to more in-depth assessment processes, like MRIs and X-ray and all that, which we don't have. They can prescribe, they can develop a diagnostic theory, and they can prescribe precision treatments to address that, whether it's a surgery or it's medicine or it's a physical therapy or occupational therapy intervention. They're not better practitioners than a competent massage therapist. They're just different we're just dealing with a different level of care. And through my years, I have appreciated not finding myself in ethical dilemmas where I'm trying to navigate a potential serious physical or emotional situation with somebody where they have seen me as their only resource. And back in the day when I started, massage was part of the alternative idea, and that oh, you know, the medical community, they were bad. They did bad things and they prescribed bad treatments and they were, you know, all this, that, and the other thing. And the alternative group over here, this is what you did instead, and don't do, you know, this and that. And there was a lot of separation and isolation and tension between those two groups. Um, and then a group of massage therapists wanted to get away from, out of the fringe idea of massage, um, and also the luxury of it, where, you know, only the rich could afford to do this or whatever. And we wanted to get into the practicality of massage therapy. So it moved from alternative to complementary. Works along with, rather than instead of. Now, I was part of that. I didn't want us to be in an instead. I had practiced that way for 10 years, and it was very stressful, you know, to be held responsible in certain ways for somebody, you know, that had significant issues, and yet they had bought into this idea, it's either this or that, instead of this and that. And that has progressed over the years now, where it's integrative, which means that we can practice autonomously. We can set up our own practice, and we can work in the health and wellness arena, and we can have our own private clients, or we can be employed in a situation where the focus is not on fragile or pathology or rehabilitative or those kinds of things that are traditionally now looked at as paid for by health insurance / medical insurance. And so then, in the historical concept of the whole thing, there were initially some classes that popped up in the 2000s, maybe even a little earlier than that, about medical massage, to move it into this idea of, now we're aligning with these more important professionals, the medical doctors and that sort of thing. And if you do that, this may be how you can bill insurance companies for massage. And that really fell apart. There is one state, Washington State primarily, there might be another one, that got written into how healthcare is provided, that massage therapists can bill direct for health insurance reimbursement. But it's not a panacea. It's not what people thought it was going to be. It's not the cash cow people thought it was going to be. And we've danced around in that. And this includes where we are right now with inclusion of these kinds of methods in the VA. Well, that's still, even though it's kind of independent, that's still an insurance-based operation. And so you get into the whole justification of benefit and all that kind of stuff that goes on with that. And so then there was the thing where it said, well, massage wasn't reimbursed by insurance, blah, 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 blah. And that's never been the case. If a person, a massage therapist, worked under an employment umbrella where a person, for another medical gatekeeper who had access to billing insurance, depending on how the insurance was billed, coded, all that kind of stuff that goes on in there, it could be covered. But the massage therapist couldn't bill directly. Well, physical therapists just in the last few years got access to direct bill. And they had to move their education up to a PhD to do it. And so, you know, it's, and so then a lot of physical therapists went out into individual autonomous practice now, where they didn't have to have referral or a connection to a medical establishment, which was the umbrella for insurance, and they're struggling. And there's a lot of competition, and you know, they've got now, instead of having kind of a department that handled all their interests, they have to build their own internal department. And you know, and this course has an underlying theme that we're trying to prepare you to work within that leaning spectrum. However, I want to, you know, so working with clients that are a little bit more complex, and where you may find that you're going to have to communicate with other practitioners in the healthcare or their medical team. You may have to communicate with the chiropractor. You might have to send a treatment plan and a narrative in. You know, you might have to do that kind of stuff. You might get recommendations back from the doctor, you know, that is, or the nurse practitioner that is coordinating a care plan for somebody who's diabetic, or you might actually get a position in like the VA is trying to incorporate massage therapists as employees. It could be, you know, chiropractors are notorious for trying to drink from both sides of the cup. And they're learning their lesson that they can't have a massage therapist that just works in their office, the independent contractor or the room renter now, because they found out, and people are getting it. There's really no such thing as an independent contractor. An independent contractor for massage is a self-employed massage therapist. That's what they are. So you're either self-employed or you're an employee. Done. All right. Now, how you work and the way you work and how you get paid and all that, there's lots of variations in that. But a chiropractor can't bill insurance for a self-employed professional. They can only bill insurance for what their umbrella covers. So if you're an employee of a chiropractor, then you are written into the entire treatment process, supervised by the chiropractor. The chiropractor pays an employment-based wage, salary, whatever. Then they bill insurance. Now, if they get reimbursed, fine. If they don't, that's part of doing business. The massage therapist is still paid.
Okay, Sandy, I have a question on that. I was going to a chiropractor uptown here, and I hadn't gone there in quite a while. And when I went back, he had this package thing, and you really didn't have an option. You had to take it. You would get the adjustment, and they would rub like BioFreeze on you and do a maybe 10-minute massage. I swear to God, she was not a licensed massage therapist, because my 9-year-old granddaughter gave a better massage than she did.
So there's a loophole there where just like a chiropractor can teach there's no formal chiropractic assistant or chiropractic aid, but they can teach a helper to do things like put hot packs on and that sort of thing. So there's a squeaky spot right there where they actually can have non-licensed massage therapists doing some basic massage like stuff.
She really acted like she'd never given a massage before.
It wouldn't surprise me. Now they're starting to, again, there's some, seeing how some, not all chiropractors, but some are trying to work those cracks where there are loopholes on stuff. And there's been, it's been a rough few years for the chiropractic community business models to adjust and adapt to many things, including this billing for massage therapists that were not really employees. Now, on the flip side of that, we've talked over and over and over about wage expectations and what can be affordable for like somebody like a chiropractor or franchise or whatever. We've talked that to death, and we can review it if you want. But in the old model, where the chiropractor was only paying per massage, that was the plan, paid per massage, and then they billed. Even if the insurance company didn't pay, there was some cushion there. And the massage therapist was not a drain on the overhead expense unless they were actually producing income into the business. When they have to convert them to employees, now they have, and again, we've talked this to death, but now they have the minimum wage requirements, other Department of Labor requirements. They have to pay the matching payroll taxes. They have to do workers' comp with them. There's all of that, and they have to pay that in regardless of whether the massage therapist is producing income into the business. And so what you will find that has happened is some chiropractors have switched all their massage therapists to employees. And they either keep them busy enough, or they have tasks that they have to do in addition to the massage therapy to justify that pay. Or they have converted them to room renters and just given up on the idea of being able to bill insurance for that. And then there's another middle ground where they're basically the massage therapist, self-employed room renter. But if there's a massage where they think that they can bill for it, then they'll hire them. They'll only hire them or pay them as an employee when they're actually producing billable time. So chiropractors in general have been the most creative in how to navigate this, but secondary to the spa industry, they're the biggest, I will use the word employer. They're the second biggest place where massage therapists are found working. So a bunch of chiropractors got caught with insurance fraud. That hit first. And then now this ongoing misclassification of employee, which is not insurance fraud. That's more out of the Department of Labor. So it's very interesting. But if we think about massage in a medical world, this idea of medical massage, dealing with a focus on dealing with something that's wrong and trying to help it be better or reverse it, the career pathway is employment. And again, as I've talked about ad nauseum, the understanding of both of the massage therapy community about employment is not good. So when they go in and they're offered a wage, so the VA base standard was just under $15 an hour, with, depending on your demographics, it would be a little more in some places under a standard government pay scale. Massage therapists thought, well, I'm worth more than that. I make more than that. But I've showed you over and over and over that they probably don't. But we have this ongoing conversation. Now, that being said, there's this background of this push continuing to occur where massage therapists think that they're going to have more professional identity, more validity in the medical setting. And so they're pushing for higher levels of education. And there was a push to get massage to where entry level was at least an associate's degree. So it would be very similar to like a physical therapy assistant. Now you can't work autonomously. That very designation means that you've got to work underneath somebody with a higher level of decision making, which is the assumption. And so I have not wanted that. I think that massage therapists should be able to pursue a career in a medical environment, understanding what I just said. It's going to be an employee situation. If the educational requirement is vocational, very similar to what a medical assistant would get, then the pay grade is going to be like that. So first responders like EMTs, they're vocationally trained as well. Now they can parlay that into a nursing degree, but massage therapists have the ability to parlay this into a bachelor's degree too. We've talked about that by being licensed and then becoming board certified and then approaching the university, Siena Heights University, and there's another community college they partner with where they can get a bachelor's degree, which Luke has done. And it's a technical based bachelor's of applied science in massage therapy. And whether he'll pursue further or not into a master's degree, who knows? But he had to have the bachelor's degree to become a co-author on the textbooks. I mean, there's academic requirements in this kind of stuff. So it's nice to be able to have that as an option, but I certainly don't want that as a entry-level point. We can make excellent decisions and do excellent work for people within this wellness, self-care, health management, affordable, self-selecting, where the person will pay for it on their own. If we can keep, especially if we can keep it affordable, and we need to then embrace, we need that part of our accountability and our responsibility is that we know and we assess to screen for safety. That's just paramount. And that we will refer if there is any kind of concern that there might be something more complex going on. And if we're seeing a client that has a more complex condition going on, we will work collaboratively with the rest of the care team. Not instead of, but along with and integrate. Now that falls apart a little bit because the medical community is so strapped and the communication can fall apart. But that doesn't mean that we can't work with that intention. Sometimes right now it's make sure you check with your doctor on this. And yes, I see you're on a new medication. We need to look at that more. Here's a possible side effect. Ask your doctor about that. It might be like that. What will happen is you build an autonomous practice like that, self-employed, is you'll get a handful of doctors, chiropractors, physical therapists, whatever, that trust you. And they will then be more apt to refer back and forth. So it's a relationship building thing. And I don't see it being any different right now because with going all the way back to entry-level education, we haven't standardized entry-level education as a massage community. Therefore, others, whether it's the clients or the general public or it's other healthcare professionals like yoga teachers or whatever, nutritionists, all the way to the medical doctors, they just never know. They don't know what the base skill set is to a massage therapist because we don't have one. So there's a relationship building that goes on with that. Now, I don't think any of the people that are in my AP program right now have an intention of wanting to become an employee within a medical setting. I don't, so we're not going to explore that in depth. You want to help people, and I want to honor that by making sure that you understand what kind of a relationship you have with them. That doesn't mean that might not change in the future. And we've got the Massage Green Spa, which is a wellness setting, but we deal with a lot of people with complex stuff. And you have to have a level of understanding about when not to do something, and then when to refer. And we've got a good reputation in our community circle with the medical community because they trust us to do that. So because you have a desire to operate at a higher level of practice, advanced practice, by learning these things, then I think that you'll find as you progress that there will be people within the medical world that will start to refer. And it typically happens with you see a client that has a family practice person in their area. And then they come and see you and you've been able to temporarily help with the symptoms of a headache. And they find that because that's all medicine can do too. All right. So nothing lasts. It's, there's very little reversal and fix. So then they go back and they say, I'm doing better. And I've been seeing this massage therapist. All right. So that plants the seed. Now, if they get 2 or 3 more of their patients that say, I've been seeing Linda, or I've been seeing Alyssa, or I've been seeing Lauren, and I think I'm doing better, and this is how they're presenting it. They're not presenting this as massage instead of what you're doing for me, but as a complementary thing along with that. And, then pretty soon they're going, here's a safe place for me to send somebody. That's how it works in the real world. So that's kind of an overview, really, of the textbook, which is trying to capture that way of being and thinking as a professional. And it just blows my mind that that book did not sell, because when it came out, there was a lot of buzz about working in healthcare, and the title. Oh, we went round and round and round and round on the title, because I just am hell bent on, I just can't do the medical massage thing. It's just it's just confusing, and it sends a difficult message for both massage therapists to live up to, and so clinical means that in addition to doing a general massage for health and well-being, we have the skills that we can focus in on some more complex types of things. And healthcare is huge. It embraces all the way from self-care and exercise and all of that to things like dealing with nutrition and mental health and all of that. And it keeps going all the way to life and death. And we got into that whole essential care, essential worker, all that kind of life and death, acute things, and then trying to get people from, they didn't die, so now they have to live, trying to get them back so that they have a quality of life. But sooner or later, there's a crossover where they're back in health and wellness, but they're still complicated. Linda, you're a perfect example of this. You've had the injuries, you've had the joint replacements, you've had mixed experiences in the medical community. You've reached out and sought other ways of managing this.
I've had to, because the medical part of it wasn't working. The essential oils got me to the point where I could at least work a full day of work. But the massage therapy has taken that so much further.
But massage therapy would not have been able. Now, I know you had a mess with the joint replacement.
Yes.
I know you did. But we would not, there's not a thing we can do. It's just, there's a limit to what our skill set can do. If somebody has a rotten joint, we have the technology. It's like the old series of the Bionic Man. We can do this. It's too bad that it was a bad job, right? Because it could have been a good job.
Right.
There are many successful. I've worked with them where their life has taken on a whole level of quality because they have been able to have some of these technological intervention. I'm one of them, with that whole heart thing. I mean, that was a very mechanical issue. I was replumbed. I was reamed out and replumbed. And I'm alive. And it went as well as it could. It wasn't perfect. I had physical trauma, not because of how they fixed the heart, but how they had to get to the heart. And when I compare that against the alternative, You know, but mechanisms that we're teaching you with massage therapy and that sort of thing can help me with that residual, right? Like it happened with you, Linda, or if somebody has other stuff that acute care medicine and and conservative care in the medical community can't just, it just can't. It tried with the morphines, it tried with the opiates to manage chronic pain. It can't. Not chronic pain. Acute pain, absolutely. Cancer pain, because it is an ongoing acute pain with the tissue damage. Absolutely. Now, not post-treatment pain, like neuralgia and some of that stuff that people will get secondary to radiation therapy or chemotherapy. The opiates don't work on that. They work on the tissue invasion cancer pain. And they work really good. So we don't want to throw the opiates out, but the medical community tried to use a really, really good thing on conditions that it wasn't good for. And then it unsettled the whole biochemistry of a person, because it doesn't take long. It does not take long for that superimposed opiate to shut down your own opiate system. It does not, it takes less than 2 weeks. And then a person is going to have some withdrawal. They're going to have a time space between when they stop using external opiates and then their body goes, oh, we don't have this. Let's wait. We're used to it coming in. The next pill's due in an hour. So we're not going to get another pill. To let's really make this person uncomfortable, so they go get another pill. To we're never going to get another pill. So now my own opiate system has got to sort of go, hey, I got to kick back in. But it's never going to be as big as the pill. And so, a person who wants that same level of relief, they're not going to get it out of their own opiates. And so now you got a horrible cycle. When you had the knee replacement, they gave you oxycodone or some opiate?
They did, but I refused it all because I can't take that stuff. It makes me throw up.
Yep.
So I went through it all with alternating back and forth between Tylenol and ibuprofen.
Yeah. When I had that root canal thing you do, that whole long story that I told you guys about, the saga of my tooth. When I went to have the root canal, the dental surgeon said, I'm gonna, here's how you're gonna control the acute pain. And he got a kick out of talking to me because I understood, the mechanisms and that sort of thing. And he said, here's the NSAIDs, and the research shows if you use Motrin and then you use Tylenol and then you use Motrin and then you use Tylenol, you get a little bit better pain control. But it's only about acute pain, only about the acute pain. And then he said, now I'm going to write you, because he was going somewhere. He said, I'm going to write you an opiate. I don't remember which one it was. He said, but please don't use it. I'm going to write it for you because I am going to be out of town. And I don't want you to be in horrific pain if there's a problem until I get back. But please don't use it. And I absolutely understood that. And I didn't have any problems with it. But I've worked with a lot of people who they like the sensation, not that it kills the pain. They like that sensation that the medication gives them.
See, I didn't even like that.
When they gave me opiates after the heart surgery, and now I'm going to tell you what, I loved them when I was in the hospital. You know, that first 3 days, that hurt like a mother. I'm going to tell you. And that and the catheter, not having to get up in the middle of the night and pee, that was great. And when I came home initially, I think I used them for like 3 days. And I didn't like the way they made me feel either. And I understood the pain. I knew that it was not, that's that hurt and harm we talked about that we're going to come back and look at again. I understood what was going on. And but that floaty, that sensation where you're starting to float away and all that, I could see how somebody could become attached to that feeling. And that's more of a psychological dependence over and above this physical dependence. So here we are, massage therapists, being seen as one of the non-pharmaceutical ways to manage chronic pain. I mean, we'll talk about acute pain, but it's really not our ballywag. Our ballywag is the chronic pain. We can help with the acute pain just by we can take the edge off the sensation or comfort or whatever. But it's, you know, it's once it's moved past that a little bit and then lingers and the sensitization and all of that. So this is where, this will be the end of this kind of blob I'm going through, but we have to think now, where do I intervene? What do we do? What are the pain drivers? How can I help? And there's the spot. We can identify the spot and we can put a different signal into the spot and we can, you know, do that. And we can interface with the autonomic nervous system, some between the sympathetic, parasympathetic, that sort of thing, so that a person isn't as fight or flighty over this. And breathing is both a it's a somatic voluntary action. I can say to you, take a breath, and you can do that. It's also a visceral autonomic action. You know, you will, they'll reach a point where you will breathe. And you will breathe whether you're conscious or not. And, you know, and if you get to the point where you're not going to do that, then artificial means like a ventilator or something would have to come into play. So it's a good little door into this controlled ability and this autonomic or automatic part. And the breathing is the rate of breathing and the oxygenation with the breathing, and that is reflective of where we are in our autonomic nervous system homeostasis dance. So there are other ways. It is not the only way. But when we're looking now on being practical and working with something that is reliable, this is a good place to think about a treatment plan. And altered mechanisms of breathing are a major contributor to neck and shoulder pain, headache, and low back pain, which are the biggies in terms of suffering with chronic conditions. So it's it makes more sense to me to focus on this instead of the more location specific trigger point, if there are trigger points in the low back that might be feeding into what's going on. Now, Linda, again, and Alyssa, remember when you hurt your ribs? Do you remember that? And you were in that subacute kind of phase. I think it had been 3 or 5 days we were in class, and it hurt for you to breathe, and it was painful, and we fooled around with it, didn't we?
Well, for me, it was my rotator cuff, that rotator.
Was.
Yeah. But you did work on that latissimus on the side and the lats and the whole thing. And also I just went for a massage on Friday where she worked on the ribs to help loosen up that shoulder also.
Is
So
that still a little bit problematic?
yes, it is some nerve pain. When I use my hand, I still get it in the shoulder. So I don't know how long that might take, 6 months, maybe a year. I don't know, but I'm not going to let it go.
Right. Yeah, it could. It could. It may, because it keeps coming back.
Yes.
It may be time to have a more in-depth look at, was there some damage in there where there's some persistent inflammation, or is there something that is a little pinchy in there, especially when you feel it in your hand? I wonder.
Yeah. There is a place on my arm that I can feel a fibrous, like not a knot, but a fibrous section. And when I press on that, or I try to self-massage that area, I can feel that nerve down into my hand. So it's there. I know I've pinpointed where to work on. And so I do that at home too. And some exercises to strengthen that shoulder.
Did you, I can't remember. Did you go and have it x-rayed or?
No, I didn't. I waited 3 or 4 days. I went to a chiropractor, and then I lucked out. The class was on the shoulder cuff. And so you guys worked on me, and it was aggressive, but I really got relief from that. And then I just did some self-work. And then Friday I went and Sarah worked on me, and so got some relief there. So I'm just going to continue to work on it.
Is it progressively getting a little better and a little better?
It's getting better. It's just localized now into that hand. When I do some writing at a certain table height, then I feel it. And so it's weird, but I just keep at it.
So if you were my client instead of my student, and we were fooling around with this, right? One of the things that I would do is I would go, now that was a pretty big fall when you did that. And real injury can hide. You can have a little bit of a, there's just a lot of little things where there's damage. There's damage beyond the bruise or whatever in there that can linger. And sometimes that can get picked up by an x-ray or an MRI or something like that. As Biden's foot, President-elect Biden, that tickles me. He's wrestling around with his dog, right? And they think initially he has sprained his foot or his ankle. And that's all. An x-ray won't show soft tissue damage. And it also won't show a stress fracture until it's almost healed. It's, there's limitations to the x-ray. So he initially had an x-ray, and then he went and had an MRI. And when they did the MRI, then they found some, I'm familiar with the injury in that area. I think he had something called a Lisfranc fracture it could have been something else, you know, but the treatment for it is a boot for a period of time, and that they wouldn't have found that if they hadn't done the MRI.
Okay.
And so that not found, then your treatment concept and your rehab concept as a soft tissue injury is a little different than if you've got an osseous or a bone injury. So, I mean, I've worked with people that have had, you know, we try and we try and we try, and it's like a sprain, dealing with it as a sprain or a strain or whatever. It just keeps coming back. And sure enough, finally I'll get them to go get another x-ray or an MRI, and there was a stress fracture in there.
Okay.
And you can pick up a stress fracture when it's almost healed, right? But a bone needs a little bit of immobilization.
Oh.
All right. And a soft tissue injury needs a little bit of immobilization in the beginning, but then it needs movement. So if it's a bone injury and you're treating it like a soft tissue injury, you're gonna miss a piece. And so it's a great example of, you know, I may say to you again, you know, possibly it's worth getting this thing looked at,
Mm-hmm.
just to get a information that we don't have access to.
Okay.
Not necessarily even that you know, if they prescribe an anti-inflammatory or whatever. I mean, this is not life-threatening,
Right.
but it would be really helpful to have a deeper look at what's going on with that. And maybe a short-term course of an anti-inflammatory or something could, or short-term immobilization or something like that, or more precise exercises, you know, treatments that are beyond my scope of practice,
Mm-hmm.
especially if I'm in a situation where I can communicate with the physical therapist or the doctor or whoever is going to do this. Maybe we can get over that hump. That's exactly how I would deal with something like that.
Okay.
Did that
Get
help
another.
you hear that
Yes.
conversation?
Yes. And to get all the parts to the puzzle. I think that's very helpful, and I can do that.
Yeah. And so, you know, you always have the decision on an individual. We're using you because you're a good example. You have the decision on what you're going to do, but you can't make a good decision if you don't have enough information.
Right.
And
Right.
sometimes avoiding going to the doctor, where, you know, your mindset is, oh, there's something really wrong, or they're going to do blah, they're going to make the, you know, that sort of thing. If you go instead with, you have access to knowledge and you have access to equipment that can give me more information. I've done that. I've gone to doctors and said just that to them. They've gotten a great kick out of it. And you know, my cardiologist now, not the thoracic surgeon, but the cardiologist, he's a good guy, but I'm sure I drive him crazy because I don't necessarily follow the information I just gave you, right? So I'm supposed to go in every 6 months just to get checked, and I don't think that's necessary. But I will go in once a year. So the last time it got to be 2 years before I got back in and got checked, and he snarfed at me a little bit. And you know, he said to me, I know that you've got a good grasp on all of this, but I can do tests that you can't do where we can see stuff before it becomes symptomatic. He says, you know, you've got a history. You need now to keep track and make sure that you're not clogging back up again, or that, you know, and that's what they're about, to make sure I'm not clogging back up again. And, you know, I had to kind of go, you know, you're right, because I didn't feel symptoms when I was clogging up until I was almost fully clogged. So it does make sense to be able, because I can't do a carotid scan, or that, you know, I can't do that stuff on my own. So, you know, I think that a lot of times, especially people who have had frustration or a bad outcome in the medical world, I think sometimes they don't necessarily reach out under this idea of, you can give me information that I can't get someplace else. Yes. And so, but I don't have to do what you tell me. You know, you get this information and then I will, you know, so so they'll say, when I go and get blood work, I'll say, I want this and this and this scan. Well, that's not part of the normal thing. I says, yeah, I know, but I want it. And if I've got a doctor that won't do it, it's looking for inflammatory markers, which is probably my main causal factor for the cardiovascular stuff. It's not part of a normal screen. And in the past, it was vitamin D levels, which now they kind of got in the normal screen. And I would pay extra for that if the insurance wouldn't cover it. And, you know, I've changed doctors if they wouldn't. I wasn't asking for anything outrageous, but I've changed doctors if they were not going to be a partner in my care. You know? So that's what I'm trying to train you to do, to work with these people that have got, and most of the people that are going to see this have got some complexity someplace. They just do. And just aging gives you complexity, for goodness sakes. So having a willingness and an understanding about being part of the solution instead of trying to do it all. When I was in a position years ago, when people saw me as their resource, that got heavy. That got really heavy. And they were not cooperative when I would say, you should go get this checked, or I don't know what to do with this because I don't know what it is. You know, kind of a thing. And it was much, I learned this when I started working with the professional athletes, where it was nice to be able to say, go let the trainer look at this. And then, you know, tell me what they said. Or with our program with the Pistons, when we were in the same environment, you know, we could walk out and say, hey, come look at this. I'm not sure what this is. You know, and 3/4 of the time they confirmed what I thought it was, and part of the time they didn't. So, but there was a respect there, because if I said, I think you should come look at this, they understood that I knew my limits. And they also understood that if they gave me information and recommendations, that I would work professionally and with critical thinking around how to do that. And if I didn't agree with them, in private, not in front of anybody, but in private, we could have an intelligent conversation about that. And that's very different than somebody saying, well, I was prescribed this medication or this thing or that, and then they go see a different practitioner. This happens quite a little bit with acupuncture, by the way. And they say, well, no, you don't need to take that. don't take that. And you know, that's not going to have any cooperative sensation to it, and the person is going to be confused and in the middle. So when a person's got an acute injury, for example, an ankle sprain, they fell, something like that, or if it's systemic illness like the flu or NSAIDs, that's your aspirin, your Motrin, they interfere with the inflammatory response. And the inflammatory response is how you heal stuff. So in the sport world, I worked with a lot of these characters who had ankle sprains and bumps and bruises, and, you know, more so than you would find in the general population. And I would ask them, what were you prescribed? And they might say, oh, it was a Celebrex, or it was a this or that, or the other thing. And I would say to them, there's good research that shows that these kind of anti-inflammatories, while they manage pain, may slow down the healing. And in that sport world, the faster they can heal, the faster they can get back out on the court, or the whatever. Time is a day can make a huge difference. In the general population, that's not necessarily the case. But in the sport world, there's somebody waiting for their job. So a day is a big deal. And so I would say to them, ask the trainer or the doctor why they prescribed the anti-inflammatory. If it was to control pain, then ask if you can do without it, because it may slow you down just a little bit. And this is when I would recommend ice. Not because it would inhibit the inflammation necessarily, but it's an excellent pain control because it's a big stimulus, and most of these injuries were local.
I used ice a lot.
Yeah. And that's not, people would say, oh, don't put ice on it, that's going to interfere with the inflammatory response, blah, blah, blah. Maybe on a ligament that's really close to the surface, but not usually, not like an NSAID would do. And so that's an example of how I might interface about a prescribed medication. You know, here's some information. This is where Medline Plus comes in, or PubMed, with a piece of research. Here's some information that might be helpful in making a decision about this medication. See if, you know, talk to the doctor, see if you can do without it or do different. So I've taken Zoloft for years. And there's been some turnover in the office where I go for general practice care, and new doctor. And so she was looking through my records and, you know, stuff. And then she says, I see you take, I can't remember the generic name for it, but I see you take Zoloft. And she said, how are you doing with that? And do you need, you know, should we take a look at adjusting the dose or trying to wean you off it or anything like that? She says, you know, you don't have to take that forever. And I probably could do something about that, I guess, but I don't want to. And it's a relatively low dose. It manages the OCD, and I don't want to fool with it. You know, I'm not in a place where I want to deal with the transition. I don't want to unsettle an internal biochemistry that's not perfect, but it's better than it was. And I was able to have an intelligent discussion with her on that. And because she wasn't the original prescriber for that. So we're good. We're good on that. Now, I got the impression of with her as a medical doctor, she's a medical doctor, not a DO, that they had the same scope of practice, a US trained DO and a medical doctor, exact same scope of practice. It's just a little bit of philosophy. I won't be surprised if she brings this up again. I think that she has a belief system where it might be prudent to wean off some of these medications, especially if you've been on them for a long time. Well, I've been on it probably 15, 20 years. And, but her response to me giving, what I said with her on that, let me know that, yeah, she might bring it back up again, but she's not going to bug me about it. She's not going to get cop an attitude about this. And then at the same time, I'd been asking for an increase in my thyroid medication for a while. I had a sensation that it was off. And the test always came back right on the edge of normal. And so she upped it. And I was pleased with that. And I sweat and was, for like 2 weeks as my body acclimated to that. But I feel much better with that little bit of an increase in the dose. So you've got to work with your medical team. You have to work with them, not against them. And if you don't find somebody that'll work with you, go find somebody else. And we can say that to our clients too. If your medical team won't work with you, go find another one. That's a little harder if they're in an HMO where there's limited doctors they can see. But there's still different doctors within the system that they can take a look at. So this whole book is based around how do we navigate this stuff that we have with the conversation, and while maybe not as fun as figuring out how to chop Luke's head off like we did yesterday. This is maybe more important in understanding the broad spectrum of massage practice. And if we function this way, we're going to get respect from that community. We don't have to become an integral, built-in, limiting part of that community. We can work together. We don't have to be absorbed by. That's a concern of mine, because I think we really have our best path of service in helping people do the best they can instead of trying to cure and fix. So, questions, comments, experiences, buttons pushed. Did I push anybody's buttons? This when I do this, I do push buttons on lots of anybody got any insight on what buttons I might push with this little speech, Linda?
Some of the stuff I've been through, it would take a lot more than that to push my buttons.
Yeah. What do you think I would have said that would be a button pusher?
I don't know with me, because I've gotten so I just kind of take everything in stride anymore. I try to anyway.
What about Yes, Alyssa.
I agree with your whole philosophy about the medical field and working with the doctor and making sure they work with you, because you are an expert about your own body and situation. They see thousands. And so I agree with you on that.
And I think the newer generation of the old guys, the old doctors that are in their 80s, if you can even find one anymore,
Right.
and the DOs, the old DOs, they're a little bit more malleable in this. They come up out of a different educational structure. And then there was that generation, actually it was a couple of generations that came out of medical school just prior to World War II or just after World War II. And then it continued way on into the 80s, where the medical doctor was king and they knew everything and you were passive in everything, and they were the miracle workers. And when you're, when you're in the process of your heart exploding, or you're really sick, or you've got a big broken leg, you want somebody that will wander and take charge, do the thing, right? You don't want them going, well, you want that. I remember saying to the thoracic surgeon that did my open heart surgery, and he happened to be a very nice man, and he had a really good interface, client care, client service. But I said to him, I don't care if you're nice. All right. I want to know that you're a good plumber. I need a plumber.
I have learned to be more outspoken when it comes to the healthcare professionals.
Right.
Yes.
And have a sense of humor and have respect. My goodness, they put themselves through a lot to get to the category they're at, but that doesn't necessarily mean they always know more than I do either. And certainly about me, so that sense of empowering. He laughed. He says, man, I wish a lot of people felt that way. I said, are you a good plumber? He says, I'm an excellent plumber. I said, all right. But he was also very compassionate. So it's nice when you've got the two together, but I would choose skill over personality.
Absolutely.
And I think we make mistakes about that.
The one that did my knee, she had neither.
Well, now.
Oh no, she didn't.
So in this conversation, you three characters, where do you think I would have pushed buttons in the massage world with this little lecture?
Knowing your scope of practice, you really need to know your scope of practice and not step outside, like you said, complementary with the doctor. Some might still be, in my opinion, stuck with the alternative. I'm alternative, and think that a lot of the things outside the box are the way to go. I think there's still a lot of people that reject medical. They still do.
And still using it instead of using it wisely. Yes,
Right.
You've hit one of the buttons.
Yeah.
Is I challenge what they think they are able to do.
Yeah.
Now,
I think it's okay to challenge, to question, but I would never reject the medical field. Like you said, if you're having a heart attack, you want a medical doctor. You're not going to say, I'm going to go to a massage therapist, for a heart attack. So we need to embrace, like you said, their knowledge.
The other thing that I push buttons on with a chat like this is professional integrity or identity, where I will call out some that they're physical therapy wannabes. If you want to function like that, then go get the degree or work with instead of, if you want to be part of that kind of an environment, then work with a physical therapist. One that will respect you for what you know and that you will respect. And I've had to work with athletic trainers where I had to really earn, and coaches where I had to really earn their respect. When we were doing that whole Alliance of American Football, that league that went defunct and put that together, almost all of the athletic trainers, the medical staff and the coaches had bad stories to tell about massage therapists, where they had hurt the client or they had told them to do something or not do something that the athletic trainer, or whatever. And it took a lot of effort on my part to rebuild those bridges. And boy, I had to get extremely firm with some of the massage therapists around the country about working respectfully. I had people drop out because they were not gonna work in this collaborative way. They thought they knew and they had things that they were going to do, and it's sad. It puts you back when you've got stuff like that instead of helps you move forward. So Lauren, can you think of anything where I would have pushed a massage therapist or somebody's button?
Maybe by trying to describe that their way of doing something is similar to something else, where they're trying to feel like, no, this is something I invented or whatever.
Oh, I did that's a biggie. Uh, more and more and more, we're realizing that the actual application thing, press here, pull there, we're all pretty much doing the same thing. There's no method out there, it's better than another kind of a thing. And these method creators, they're having a hard time. And it's not just massage. I mean, this is in physical therapy and some other things too, where they've got to really shift and try to come to grips with this biopsychosocial model. What I do affects structure and the physiology. And it does, just not maybe the way we think, okay? And it's temporary, usually, not permanent. You can get long-term results, but that's secondary to something else. It's always a long story. I always have to tell a long story. I can't ever tell a short story because there aren't any, when it comes to stuff like this. And, so they're not doing the manual therapies anymore because there's been this philosophy, it doesn't work. We need to educate. We need to talk to them about pain sensitization and da 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 and how chronic pain is this and that and the other thing. And now what they're starting to realize is as they shift their practice, people are frustrated because they want to be touched. They want to come in. They want some interaction. They want somebody to put their hand on where it hurts, for crying out loud. Whether it has tissue damage there or not, to them, it hurts. And, that whole thing. And so they're struggling. They are so struggling with what is going on within all of that. And, people want to be touched. They want pressure. They want you to put their hand, they want the spot. They want you to touch the spot. But we don't have to make unsustainable claims about what we're doing, and we don't have to call it a brand new name. And so that's really screwing with the continuing education market, let me tell you, because the massage therapy community has been dominated by some continuing education gurus. And people take their classes and they've got all these things that you do, this stuff that you do. And now the current research is not necessarily supporting that. So you're entering the field at kind of a fun time. So here's what I would like to do. I would like to stop the recording for a minute, let everybody get a chance to get up and move around. And then I'd like to go back and revisit the PowerPoint from yesterday a little bit and give you some more resources to look at on that. Does that sound like a plan? All right, let's do it. Somebody make sure I restart this recording. Okay. We're back. Yay. So we went over this a little bit yesterday. And everybody's been able to get into the book. So that's good. And the releases that we've been fooling with, there's good pictures of that in there. And so we've been fiddling around with this expansion of scope of practice from entry-level training into responsible interface with people that maybe aren't optimally healthy, like most of us, right? There are cautions that we have to stop and consider. So I want to flip through all of this, and I want to come down to something right here. And I actually have to stop my share and then come back in. So, hi everybody, here we are. Oh, I look rough.
Oh, you look good.
What are you gonna do? All right, so share the sound on the computer. All right. This link, if it works right, is going to take us to a YouTube it's hosted on YouTube that Dr. Leon Chadow did. And we're not going to watch the whole thing because you can get it up and watch it. But I want to watch just a little bit of it with you. I have had two great teachers and lots of really good ones, but I've had two great ones. One was Dr. Girovich, who was the Russian physician that immigrated here to the United States. He was brought in under refugee status when the Berlin Wall and stuff was coming down, and it was getting rough for Russian Jews in certain areas. And he was a Jewish physician that was recruited during World War II by the Russians. And there was anti-Semitism in Russia too. And so the Jewish doctors were put in positions where they were put in higher risk. So he, for the course of the war, and realized that Europe, they were at war years longer than when the United States went in. So a 3 or 4 year war for us was more like a 6 to 8 year war over there. And So he paratrooped into behind the lines, and did emergency battlefield care. And when the war was over, Jewish doctors were not necessarily given the same status and therefore the same opportunities. And so he ended up with his wife, who was an obstetrician, ended up at a rehabilitation hospital in St. Petersburg. And he worked with the disabled veterans and others. And he used a lot of physical medicine stuff. And I learned a lot from him because they operated at a much lower technology. A lot of his skill set was very similar to that you would have seen in physicians prior to the 1920s, you know, where they still, that was the doctor that went to the house, and, you know, they practice medicine like that, innovative sorts of things. So an example is that if you've got a bone break that won't heal, they'll put a bone stimulator on it, which runs a electrical current through there, or it will tap at a regular basis, and it causes cellular proliferation, cellular division through actually the piezo responsive bone, which is a crystalline kind of structure. Anyway, if you run an electrical current through it or you vibrate it by beating on it, it stimulates the cell growth, and it helps fractures heal a little bit better. So they didn't have the machine. So they would have technicians that would rhythmically beat at the end of a long bone, you know, like your leg bone, in order to stimulate bone growth. And so a lot of the interventions that I teach in AP, I learned from him. And the other is Dr. Leon Chadow. So Dr. Girovich was an MD, but when he immigrated to the United States, he was already in his 60s, and he couldn't just transfer his credentials. And he was with the school almost 10 years. So I had a chance to learn from him, and he taught at the school and that sort of thing, and then passed. So I'm very fortunate. And then Dr. Chadow came into my life early in my career when I was looking for something that wasn't goofy, to understand what massage was all about, that wasn't pseudoscience, you know, and over here and mixed up with a lot of spiritual. So I just wanted kind of the, you know, and he wrote a book called Soft Tissue Manipulation, which I got my hands on, and it framed a lot of the information that I was trying to make sense of. And so I reached out to him and pretty much did what he told me to do for 25 years. In order to be in his presence. And then he passed in 2018. I think maybe it wasn't your class. It was the class before that when I got the word that he had passed. And his daughter actually called me a year ago to see, because he'd written tons of books, tons of them, and asked if I would take over one line of them, the muscle energy technique and positional release, and you know, those kinds of things that we were talking about yesterday during that video. So these two were very different. They're both European, these two doctors, Dr. Girovich and Dr. Chadow. They had different ways of interacting with me. And one was not any better than the other. But they were in my life a long time, and they came from a different background. Also, I grew up under osteopathic care. The older system, where there was a lot of manipulation and a lot of osteopathic technique and that sort of thing. Up here in Lapeer, in the middle of Michigan, especially years ago, you couldn't get a medical doctor to come up here. So there was a hospital in Pontiac Osteopathic Hospital. I don't know if any of you remember it when it was an osteopathic hospital. It was been taken over now, but then they had out branches up into the Michigan area. So Lapeer Hospital was originally an osteopathic hospital. So early in my career, I ended up working with a lot of osteopaths. They would come to me, and then they would teach me stuff that probably was out of my scope so that I could do it to them, right? Okay, so as I started teaching, I had to take that content and I had to make it fit into our scope a little bit. So I've had a lot of influence from that direction. And I remember one time Dr. Chadow was in town teaching and Dr. Girovich was in the class. And he was old, he was a little older than Dr. Chadow. So there was a little bit of, Dr. Chadow was from South Africa and living in England, and Dr. Girovich was from Russia. And there was a little bit of competition going on. And so I would see Dr. Girovich in the back of the classroom going, I do that. Like it was like, this isn't that special. I do that. So a break, they were both in the classroom and they were interacting a little bit. And Dr. Chadow would, because it was a language barrier, so they would actually, Dr. Chadow could speak some Russian, but they would work. He'd show one thing and Dr. Girovich would show the other, and then they would, I've been so fortunate to have had that kind of education. And Dr. Chadow, I've always mispronounced his name. He has quite a legacy of books and videos, and I wrote a series with him and all of that. And I learned a ton from him, more theoretically. So he was the one that really brought the whole issue around breathing pattern disorders and that sort of thing. And so he's got a book about chronic pelvic pain, but because of the relationship between the pelvic floor and the diaphragm and how one interacts with the other. And, he does an introductory piece to this that has a lot of nice information about breathing. And so I would like to introduce him in a sense to you. And he has a website that has access to a lot of videos and a lot of books. And you can also just put it into a search program, YouTube search program. So I'm going to try to open this and see if it will work here. Come on. Can you hear it? hips.
This is an image which I love because Sally here represents all of us in terms of the baggage she's carrying. She's adapting to life, and she has many burdens. And we adapt until our adaptation processes can no longer cope, and adaptation exhaustion sets in and symptoms emerge. Reducing Sally's load and enhancing her adaptive capacity, these are the two key things that all of us do in any therapeutic effort, is actually either just treating symptoms, which is one aspect, or we are reducing adaptive load, or we're enhancing functionality. And that can be on a biochemical, nutritional level, it can be on a psychological level, it can be on a biomechanical level, or it can be a combination of those. But that's all any of us can do. We need to consider the unique attributes of our patients and try to remove adaptation demands, lighten the load where Sally's concerned, enhance functionality by focusing on the whole person. And remembering, this is important, that any therapeutic intervention, change your diet, more exercise, modify structure, modify anything, is another adaptive load. So it's fine-tuning what we ask patients to do or what we do to them, to their ability to respond. Because it's very easy to overload an already over-adapted decompensating system. The analogy of a piece of elastic that's stretched so far that anything else is going to make it snap, we've got to try and reduce that stress, introduce more resilience, more elasticity. We need to encourage and educate and explain whatever it is we're asking people to do, not just tell them what to do. There are biomechanical approaches, biochemical approaches, psychosocial approaches, and people need to understand the concept of self-regulation. Patients need to know that all we do to them is to enhance the functionality of self-regulation, homeostasis. Nothing that you do cures anything. People cure themselves, or they improve themselves by their activities. We need a couple of definitions. There's a European definition and an American definition, and we'll just have a quick look at them. It needs to have been around for at least 6 months to qualify as chronic, and it needs to be related to the structures related to the pelvis. That's from fall in the European Urology Journal. American definition requires that, again, 6 months. They talk about it involving the pelvis, the anterior abdominal wall, lower back and/or buttocks, anything between the umbilicus and the hips, front, back, sides, inside, that is painful chronically, is chronic pelvic pain. It is not just the urogenital area. It can be irritable bowel, it can be pelvic pain of a biomechanical nature, sacroiliac, low back. All of that is chronic, if chronic, is chronic pelvic pain. So
now, one of the things that is frustrating when we appreciate these bigger functions, and people that have pelvic girdle, which includes low back, can go down into the legs, when they have dysfunction in that area, we've gotten into the massage world where those are the exact areas that we quote shouldn't massage. The abdomen, the gluteal area, higher up into the thigh, and with breathing into the chest area, where we're not us, but the community has gotten so afraid of some sort of misconstrued, inappropriate touch that it interferes with us doing some soft tissue work that can improve these symptoms and increase adaptive capacity for a little while. So, I mean, you guys remember back when I would get after you about massaging the glutes, you know, and the hip area and the low back, and what are you going to do about it? And so this is a real limitation in the massage world on how it keeps us these perceptions of what's okay to touch and what's not okay to touch, and the still remaining overarch into sexual interaction or inappropriate ideas. You know, it's a little frustrating on my part. So anyway, I just wanted to point that out.
Anything to do with the content or the structures that support the pelvis can meet that definition. Current mainstream appreciation of the CAM influences suggests that not only the organs, but also the muscles, connective tissue, that's the fascia, neurological input, all of these need to be evaluated. They talk about this in women, but it involves men as well. And the text that I put in the red-brown color takes us to the one aspect of this, the susceptibility of the pelvic floor musculature to the development of myofascial pain. Myofascial pain, trigger point activity, we will see is a key element in some of the research that shows what can be done. This is a recent paper by Hartman and colleagues suggesting that pelvic floor hypertonicity, we used to think about pelvic problems in terms of laxity, in terms of people need to do Kegel-type exercises to tone the pelvic floor. What we're seeing increasingly is high-tone pelvic floor. Gymnasts, athletes, people who work out a lot, excessive amount of activity can lead to a short, tight pelvic floor that doesn't function adequately, and that will impact on breathing function and on pelvic pain. So the key points here so far are we need to have, to meet our definition, pain for more than 6 months, anywhere below the umbilicus and above the hips, side, front, back, or inside, equals chronic pelvic pain. Every now and then I'll bring up one of these slides, which is like a summary of where we've just been. So now you know what we're talking about. We need to understand pain a little bit. There are lots of misconceptions about pain. Much pain has no pathology. Many people with known pathology report having no pain. So you may have scans which show all sorts of anomalies, no pain, or people in pain and scans and other imaging shows nothing. More than half of people with MRI anomalies in their lumbar spine have no pain. Objective medical evidence findings don't predict pain. And the most consistent biomarker for chronic pain involves changes in the function and structure of the brain, cortical areas of the brain, whatever the diagnosis. And this is the shorthand of that is pain is in the brain. Does that mean we ignore the periphery? Well, we'll see that that's not the case, but in essence, pain is in the brain. And we call it central sensitization. The brain becomes hyperreactive. So if we look at this image here you have heat or some other pain generator, and what the person feels is pain. This is normal. And here we have a feather tickling the person and they feel touch. Those things are separate. I touch myself, I feel touch, I don't feel pain. I press hard, I feel pain. When you are sensitized, those same stimuli, heat or whatever, pricking, whatever, would produce a hyperalgesia, excessive amount of pain, and touch, the feather, might lead to pain, allodynia. So it is an increased sensitivity. So it's basically that low thresholds of sensory input can activate the pain circuits. So the person's degree of sensitivity has changed, their pain threshold has changed. And this is with all chronic pain, not only pelvic pain. How do you recognize central sensitization? They're not only sensitive to pain, but to light, touch, noise, chemicals, and temperature and other things. So current mainstream approaches are mainly biopsychosocial. Cognitive behavioral therapy, helping the person understand and manage their pain, is seen to be the way forward, and that is very, very effective. But there are other ways. One can reduce that sensitization by reducing the peripheral generators of pain. That, unfortunately, is not what mainstream medicine is looking at so much, except in some countries, like Italy, that is being looked at. So dealing with sensitization, we need to reduce the combination of factors that are feeding into the pain. I know this is generalized, this is not pelvic pain, but we're coming to the pelvic bit shortly. Deactivate trigger points, myofascial pain sources is one way. Removing scar irritations, the neurological effect of some scars can feed into the process. Improve functionality, spinal and joint. Improve muscle recruitment, strength, flexibility, motor control, etc. And pay attention to the features such as diet, lifestyle, and habits, as we all recognize their impact on this, and consider psychological features. This study by Italian researchers, Affaitati and colleagues, is, I think, foundational in where I'm taking you next. They showed in a randomized placebo-controlled trial that by dealing with local muscle and joint sensitivity, they could reduce central sensitization. So here we have something which is actually saying, yes, this person has extreme sensitivity, as wherever the pain is. It could be fibromyalgia pain, could be any other form of pain, chronic headaches, migraine. In this case, let's just stick with pelvic pain. By looking at Sally and removing some of those bundles, some of those pain generators, or modifying them, as well as helping her to cope with the stresses of life in general, the pain element changes. Pelvic pain can change. A team effort is seen to be ideal. To identify the causes, a complex team effort in the absence of pathology, biomechanical, psychogenic, biochemical, metabolic, and/or neurological features, and none of us, nobody knows everything about all of this. We need different inputs if we're going to look at the whole person. And they may benefit from manual treatment, psychotherapy, biofeedback, neural interventions, medication, nutrition, surgery, and so on. No two cases are the same. A recent study published this year in the Journal of Obstetrics and Gynecology clinics from North America. This is about adolescents with chronic pelvic pain. And it's interesting to see how this is seen from a mainstream perspective. All sorts of interventions may be needed, but involving specialists familiar with gynecological and non-gynecological causes. And apart from mainstream approaches, medications and surgery, physical therapy, trigger point injections, psychological counseling, complementary and alternative medicine is seen to be well integrated in the American model. So the key points are that if central sensitization is a feature, as is common and usual, team approach is best, and that we need to think about, I may not be able to deal with the features involved in this person's chronic pelvic pain. It may be ancient trauma, it may be all sorts of inflammatory processes in the past, leaving internal scar tissue or neurological damage, but you can deal with whatever peripheral aspects you can in order to modify pain.
So can you see the influence? Can you see his influence on me? As we, I lots of times hear his voice coming out of my mouth.
Now I'm not seeing a video.
Link between breathing.
What's that, Alyssa?
I'm not seeing a video. I'm not supposed to, am I?
Yeah, there is a video. You're not seeing it?
No, but I am hearing him.
Okay. Let me,
How about
I
everybody?
thought we were only supposed to be listening to him. There is no video.
there is
Yeah.
no video. So I stopped the screen share. And let's go back. Let's try this. Let me know if this is better.
Yes.
Patterns,
You got,
the whole respiratory
Yes.
function
all right.
and the pelvis. So here we have the pelvic floor with all
So I want to show you Sally because he refers to
the improving, enhancing functionality. And that can be on a biochemical, nutritional level. It can be on a psychological level. It can be on a, represents
Sally.
all of us.
with, you know, all these burdens that he's talking about and how the only way, there are many different ways to help her. One is to get rid of some of the burden and the other is to help her deal with them better. But I'm sure we can all recognize ourselves in that picture.
In terms of the baggage, it can be irritable bowel, it can be
So somebody say, yeah,
pelvic pain
video
of a biomechanical nature, sacroiliac, low back. All of that is a short, tight pelvic floor that doesn't function
see it.
adequately. That will impact on breathing function and on pelvic pain. So the key points here so far are we need to have sensitization, then diet, lifestyle, and habits. As pelvic pain, by looking at Sally and removing some of those bundles, some of those pain generators, or modifying them, as well as helping her to cope with the stresses of life in general, the pain element changes. Pelvic pain can change. A team effort is seen to be ideal. To identify the causes.
off here.
This is about adolescents with chronic pelvic pain. Team approach is best, and that we need to think of the pelvic floor and the behavior of the diaphragm. Diane Lee from Canada, if you would go to her website, dianelee.com, in Vancouver, has done so much work with this, and showing that the evolution of pelvic pain may have started with a breathing pattern disorder. Now, this is a flow chart. Try to remember some of the intricacy of this. We're going to go through it bit by bit. Stress, the problems of life, traumatic events, unconscious fears lead to anxiety. Anxiety changes the way we breathe. You breathe more rapidly and more upper chest when you're anxious, and when you breathe like that, for other reasons, you become more anxious. So there's an intimate interchange there. This causes sympathetic arousal, the fight or flight mechanism. And from that, you get a whole range of symptoms, which themselves can be frightening, and they feed into anxiety. So there's the rapid pulse, the sweating, the panic type feelings. So that's just the basic stress response. The upper body becomes more restricted, more held more firmly, and breathing becomes more rapid. There is a direct correlation between upper chest breathing patterns and head, neck, shoulder type symptoms. And that in itself can feed back into the frightening anxiety pattern. That part is very basic. Now we get to the really interesting bits. When you breathe too fast, you lose too much carbon dioxide. As that happens, since carbon dioxide is taken from carbonic acid in the bloodstream becomes more alkaline. And a condition known as respiratory alkalosis kicks in. The body tries homeostatically to rebalance that by excreting calcium bicarbonate through the kidneys. So you become too alkaline, and the body doesn't like it, so it gets rid of calcium and other ions. Low calcium causes nerves and muscles to function poorly. That changes pain threshold amongst many other things, but it has psychological effects. Panic and impaired memory may kick in. Physical effects include exhaustion, tingling, cramps, weakness, altered motor control, reduced pain threshold, poor altered balance, etc. And there will be myofascial effects. The diaphragm will respond to an upper chest breathing pattern. It's not getting its normal excursion. When you breathe normally, the diaphragm has a real doming effect and flattening effect. When you're breathing upper chest, the poor thing is just fluttering. It doesn't get exercise, and that has a direct effect on how the pelvic floor functions. Something else, something called the Bohr effect, BOHR. When you're in an alkaline state, there's a smooth muscle constriction, and the blood vessels and the tubes of the body, that's the gut, the urethra, and all of that, narrow. Smooth muscles constrict. So you're going to have gut problems. You're going to have less blood delivered through the blood vessels. That's going to create ischemia and fatigue, and that is going to lead to the evolution of myofascial trigger points, which actually breed beautifully in the body in an ischemic state where there's too little oxygen. All of that's frightening, and all of that is worst in women post-ovulation, because progesterone levels rise, and that leads to faster breathing. Most premenstrual symptoms link directly to breathing pattern, and all of this is going to obviously have an effect on the pelvic floor. So I think you can see from this flow chart, if you have something like this to show to patients, prospective patients, as an educational tool, you can show them why feeling anxious and panicky and or having head, neck, shoulder pains and or having any of these symptoms may link directly to their breathing, and all of that may be associated with pelvic pain as well. I also show people this little mannequin or womanikin, whatever she is, and the number of symptoms that can all be linked directly to breathing pattern disorders. And that, of course, includes pelvic pain. Don't for a moment think I'm saying that all pelvic pain is caused by a breathing pattern disorder, which is not a pathology, it's just a habit of breathing. But all pelvic pain will be influenced by it, and it may be amongst the causative features. When you breathe upper chest, on inhalation, instead of there being the diaphragm falling down and slightly pushing the abdomen forward and an lateral expansion of the ribs, it may all happen at the top in the upper chest. So you end up with what's called paradoxical breathing. But you've also got paradoxical effects in the bladder area, in the pelvic area. If you have an urge to urinate and you're sitting in a theater, you're not going to want to do it right now, I hope. And so you're going to sort of like retract a little bit and hold things in, and this effect happens. There's a sort of a slight lift of the bladder. But if you have paradoxical bladder behavior and you try to do exactly that, you can have stress incontinence, and instead of your bladder rising, it will fall and you will wet the seat, which wouldn't be very nice for anyone. So pelvic floor paradox is direct correlation with breathing, respiratory paradoxical breathing. And it's a key feature in the evolution of many pelvic pain problems. Similarly, there's direct link between colon spasm, irritable bowel, which again is a pelvic pain, and respiration. That's a study way back in '95. Found a direct link between breathing pattern disorders and irritable bowel. Similarly, links between core stability and the way the body supports itself and breathing function. Studies by McGill, Hodges, and others show that when you breathe upper chest, core stability diminishes and the body isn't as stable, and low back pain and other dysfunction can occur. pelvic girdle pain. Pelvic girdle is the bony structure that surrounds all the stuff inside and that attaches to it. Lots of studies showing the link between breathing pattern and poor pelvic girdle function.
Now, can
This
you
is
characters hear me? Somebody say something.
Yeah, I can hear you.
Yeah,
Okay.
yeah, we can hear you.
All right, so this diagram, I want you to think about the various releases that we have learned or we're going to learn, okay? So this is the diaphragm. We work with that a little bit. This is quadratus. We're going to try to think about working with that. These are the abdominals as they wrap around from the low back. Remember, we've talked, you know, your front starts at your back and your back starts at your front. This is the psoas complex. Iliacus is here on the side, and then this is this pelvic floor. And while we don't massage that area directly, I am going to teach you how to apply some inhibitory pressure in the general area that may affect the pelvic floor, particularly some of these lower areas. So then we're going to have to grapple, as we work in that area, we're going to have to grapple with, you know, the preconceived ideas about inappropriate touch, etc. So that becomes a situation. But yesterday I told you all of the pretty much the releases that you're going to see in the textbook and that we're sequentially working through showing you, those are the things that, in addition to the regular massage, the general massage, that you would assess for and possibly choose to try to do an intervention with.
There's an Australian study by Smith, telephone survey of over 38,000 women, found a strong association between back and pelvic pain, incontinence, and breathing disorders. They feed into each other. And an enormous amount of correlation. This is from a Norwegian couple, Haugstad and Haugstad, husband and wife. And I like this quote from them, or these two quotes, that typically women with chronic pelvic pain display upper chest breathing patterns with almost no movement of the thorax or the abdominal area. It's all happening at the top. They also confirm, and this is another, I think, very strong quote from them, and they've done an awful lot of work in this field, characteristic pattern of standing, sitting, and walking, a lack of coordination, irregular, high costal respiration, upper chest. The highest density and the highest degree of elastic stiffness they found in the iliopsoas muscle. And there again, we have, that's the link from psoas via the pelvic floor up to the diaphragm. So that's a confirmation. It also tells you something about where you need to pay attention if you're a manual therapist of any sort. Think about psoas, and we're going to look at one or two ways in which that can be done. Key points here: breathing patterns are intimately, structurally, and functionally connected to pelvic problems and must always be considered. So you may think you may be a nutritionist or work with stress management. You need to think of the biomechanics. If you are a manual therapist and you don't know about other elements except the structural, you need to think about working with or cross-referring to people who work with stress management and nutrition. It's a team effort. Posture, okay. We'll just look at this very quickly. Neither she nor he could possibly have normal pelvic function. The pelvis is in the wrong place. The diaphragm, neither of them can breathe normally. So the summary here gives you a sense of what's short and tight and how that imbalance fits together to produce functional changes in breathing and in pelvic function. So part of what we have to try and do is modify. Now, you're not going to get either this lady or this gentleman back to anything like where they were at age 20, but you can improve the function to some extent. This is a part of the body which is, we know about it. This is the thoracolumbar fascia. So down here you have, this is the sacroiliac joint area here, roughly. And so here you'd have your sacrum. So there's your triangular sacrum. And here you have links down to the hamstrings. So down here somewhere are the legs. And this huge blanket sits from the pelvis up to the shoulders. Shoulders are up here somewhere. And it links to everything. So here you have the sacrotuberous ligaments, and here your gluteal muscles. Then you have your internal obliques here, and serratus posterior inferior there. You've got your erector spinae connections. Latissimus dorsi is up here somewhere. All of these are linked to each other. And if you're going to have pelvic pain, it's going to be in this area. And if this structure, which links and shares load between all of these muscles, is dysfunctional in any way, problems arise. So here we have fascial structure. It's not moving. My first thought was, okay, how do we get the darn thing to glide again? Because this person has low back pain, and that's pelvic pain. There are ways of encouraging the production of hyaluronic acid, which is the lubricant that helps it to slide. And so that was my first thought. And when I put that in a conversation with the researcher whose film this is, Helena Langevin, who's from Harvard, she said, very gently, she said, no, Leon, think another way. Here you have a structure which can't slide or glide. Could there be excessive strength, tone in all of these structures so the damn thing can't move because it's being pulled in 15 different directions? So maybe the way to get it to slide again and help the back pain is to release the hypertonicity in those muscles. And if that doesn't work, then think about doing something to get the hyaluronic acid level. So we have to see it objectively.
So that's pretty profound. So we're trying to help you think about not just a unilateral focus, not just connective tissue or not muscle, but all of the muscles he just had listed, those fall into these quote release categories. So, and the inhibitory pressure plus movement, what that's doing is bringing the tone down. So the pull on this sheath like a trampoline becomes a little less intense, and therefore it becomes a little less stiff. So we're going to look at just a little bit more of this, and then I want you to be committed to watching the whole thing again and watching it all the way through.
Here we have a great example of what not to do if you're youngish. Anyone who does too much squatting type activity, and examples are given: American football, weightlifting, wrestling, baseball catchers, where you're in a squatting mode in your developmental years, you can end up with the problems that this chap had. And you may be able to see a little sort of shadow there. Excessive tone on the obturator muscle has actually created an increase in bone, and that is causing pressure on the pudendal nerve. So this person had chronic pelvic pain. The X-ray shows the altered shape. On the left, ischial spine. Ischium is the thing you sit on. Those are your so-called sit bones. Right here, internal structures, muscles in the pelvis, and you can see what sort of stress and strain would be going on in that kind of activity. So we have here the beginning of a sense that what people do, especially in athletics and in repetitive activities, this could be someone in a gym doing this 20 or 30 times a day, 4 times a week. Not a good idea. Something else they might be doing is sitting on a bicycle. Chronic pelvic pain and cycling are directly linked. Not that cycling in and of itself is necessarily harmful, the shape of the saddle pressing on intimate bits of you, and the shape of your seating and your angle of riding, and whether you ride 10 kilometers or 300 kilometers a week, as some people do, will have a direct effect on, in this case, these are studies of erectile dysfunction, but they would be linked to chronic pelvic pain. And the structures that are most at risk there are neural structures, which are being compressed and distorted. So we have sporting activities or activities that involve repetitive crouching. We have possibility that just excessive exercise in and of itself will produce high tone pelvic floor. We have cycling. And the outcome is not good, especially in females.
All right, now, let me see if I can get rid of him for a minute. I gotta find that. There. Now. All right, I'm working on it, you guys. All right, are you there? Have I found you? Okay, so give me some impressions.
Very interesting.
How so?
Just all the different information that I guess I never knew about.
Go ahead, Alyssa.
Well, I am, every time we come to this area, which we have studied in class before, William Nasser comes to mind. And I'd like to know what you think, and because we know what came through the television sets and newspapers about that, but what do you think about what happened in his case? And is that, I mean, that's what comes to mind every time we study this.
Okay, so Nasser was the sports doctor. Was it Michigan State or
Yeah,
University of Michigan?
I think it's, I don't remember actually.
He was accused of sexual inappropriateness, sexual misconduct. And towards the end of this video, just towards the end, Dr. Chano talks a little bit about internal work, either through the rectum or through the into the vaginal tract. Okay, so if I were going to make a guess, this particular person probably learned these techniques, had an awareness. I'm not sure if he was an MD or a DO, but he moved away from the true therapeutics of working with this and got involved in his own sensations with it. And that is the point where it became abuse.
Okay.
So, because he did say in his trials, he said, well, this is a therapeutic intervention. You know, I was just doing a therapeutic intervention. Okay, I learned those. I know how to do those types of therapeutic interventions. But I didn't, or you know, where's the line?
Yes.
You don't do this unless it's absolutely necessary. You work from most conservative forward. The population he worked with, that's kind of where we stopped the video, population he worked with fits the criteria for having chronic pelvic pain, and with the whole diaphragm inhibition and the breathing pattern disorder, along with the anxiety. I can see all that. I can understand all that. But you don't take sexual pleasure from offering a therapeutic intervention. And he started doing things like not using a glove. And so that's where that's
Okay.
the issue. Does that make sense?
Yes, and also when you were talking about TMJ, you were talking about interventions which could go inside the mouth or whatever. Are there ways to do what was necessary without invasive
Yeah,
training? I mean, okay.
yeah. And so my guess then is he started because he enjoyed,
Well, sure. Yeah.
right? He enjoyed the young athlete, and he enjoyed he had a sexual response to all of this and everything that went along with that. He would not do. So Dr. Chadow, if you follow this through, you work externally. We already made the connection. Look, this thing starts at the shoulder. You know, that the fascia is there, latissimus comes around, you know, and this attaches to that, and that attaches to the other thing, and then you got the hamstring in there, and you got the abdominals in there, and you got all this stuff in. Do that. All of that will reduce the strain into this target area of this video, which is the pelvic floor. I wanted you to watch this because the initial part of it has got a really good synopsis of the pain and sensitization, and then the breathing pattern disorder. That was my initial main focus on that.
Mm-hmm.
And I wanted you to see him in action, you know, how kind of his approach and his tone of voice and how he talked, and, you know, get a sense of that. It's like with acupuncture, traditional Chinese medicine truly rarely uses acupuncture. It's equivalent to an invasive surgery. There's lifestyle and dietary changes and movement and a form of massage and all of that before you go straight to sticking a needle in something.
Okay.
So, you know, he has always said general non-specific first, least invasive first. And I took that to go, look, do a really, really, really good general massage. Bring as normal applicability and tug-pull relationship to those structures as is possible. Give that a chance to work. Then maybe we need to tweak a little bit.
Okay.
And that's where these releases come in. And so, you know, instead of jumping right to the, you know, and so that's, you know, it's just like when we work, I can't imagine working with breathing and general relaxation stress response without working the lumbar hip area and the abdominal area. I can't, and the thorax, the anterior chest. And then when we get into limitations of massage and appropriate touch and all that kind of stuff, those places are totally eliminated because they have a sexual override. Well, when I work on those areas, I don't have a sexual thought, but somebody else might. Or the client might.
The client. Yeah.
Yeah.
You know, and so now it's confused. And we do have to be careful. We do have to be cautious. We're going to do work in areas where there could be misconception. Then we have to be able to justify it, thoroughly explain it, and find ways to do it where it's not going to have, it's not going to feed into that perpetual or that perceptual thought process.
Right. Okay. Thank you.
good, good, good. How about you, Linda? What'd you think of my teacher mentor?
I had watched that one before.
Had you?
Yes, I had, mainly because I think it drew my attention because of the pelvic area, the pelvic floor and everything, and I wanted to see if there was anything I could learn about that to maybe help somebody else. And I have had acupuncture done before to, my meridians were out of balance. And it took about 6 sessions with that to,
Yep. You know, so this is, again, even though we're virtual, this is a typical Sunday morning that we would have, is that we would, look more theoretical. In advanced work, it's more, it's less about method and more about understanding the bigger picture and how things fall together. Did any of you get a chance to fool around with some of the method we had on the video yesterday?
I just worked on myself and I tried it out, like I said, on my dog a little bit. And I didn't go anywhere yesterday. I was finishing my bathroom. So,
Uh, so
Just feeling the landmarks and stuff on my own skull. I did that. And some of the things that Luke, talked about self, where the sternum and the stretching of the neck and stuff, kind of just feeling, and copying what you guys did.
yeah, if I understand how it feels on me, then I can understand when the person's trying to describe it to me.
Yeah.
Even if I don't have the pathology, if I do the method, I go, oh, okay, so that's how they're feeling all the time, not, and then so I can start to have a little bit more, I can screen the information a little bit better going on with that. So what I would like to have us do is, I think we've covered a nice chunk of information today. I personally don't see the need for a follow-up call this afternoon. What I would like for you to do is watch that other research webinar out of the Massage Therapy Foundation. And go on to Dr. Leon Chadow's website and/or explore more of the YouTube videos he has posted. There's ones on trigger points and one on, he and I wrote like 4 or 5 books together. So there's videos that went with that, and kind of absorb over the next month kind of his philosophy and his legacy. And he was never stuck in his stuff. He was always evolving and looking at things in a different way, and at the same time he was talking about things before it became popular. I was learning about what they want to call this pain sensitization and the biopsychosocial and adaptive law. I was learning about that way before it became popular in the massage world and became clicky and gimmicky in the massage world. And I'm going, well, why does anybody think this is new? This is not new,
Right.
It wasn't new to me. Give yourself this month to kind of explore him, his philosophy, his background, his way of thinking through a problem. There's lots of resources out there for you to be able to do that. If you know this now, if you come up with any questions or if you need any guidance on anything, you just give me a text and I respond. And if I don't, it could have just gotten by me. I didn't notice it. Text again. You're not going to bug me. If I want to ignore you, I can ignore that. but then I might forget that I was ignoring you.
I
Uh,
wanted to ask a question of, I was on a used textbook site, and they had Leon Chateau, a breathing pattern, a textbook right on breathing pattern. It was very low cost. Do you
Yes.
think that that would be a good thing to purchase?
Yeah,
Okay,
pick it up and get it.
okay,
Yeah. And he's got good pictures in there. Now, he was a co-author on the clinical massage book that you guys have got. I don't know if you processed that or not, but one of my favorite, there's 2 books that I love with him. Breathing Pattern Disorder is one of them.
okay.
And the other one is the very first one that I got my hands on, which is Soft Tissue Manipulation. It's got a blue cover on it.
Okay.
And yeah, so if you come across those inexpensively, pick them up. Yeah,
All right.
absolutely. So, okay, ladies, chew on it. See where you go with it. Do watch the video we did yesterday again, just for the chuckles. Just
Okay.
for the chucks. And then I'll keep you posted on what we're going to do for January. Just depending on what's going on, we may be like this one more month or not. I don't know. We'll just have to see what's going on. And like I say, you know how to find me.
Okay.
All right, you guys, and have a peaceful holiday season.
Thank you. Yeah, you too.
Merry Christmas, happy holidays, and all the rest of
Everything.
Yes, it is.
it. I appreciate all of you.
We
Same to
appreciate
you.
1, 2, 3. We're going to end her right now.
All
Okay.
right. Bye.
Bye-bye.